Good morning everyone. Today the topic we are going to discuss is on habits in Department of Orthodontics. Myself, I am Dr. Lakshmi Prasanna, Professor and HOD from Department of Orthodontics. So you all know, everybody knows that habit is a word generally we will talk very frequently, that don't acquire that habit, don't do that habit, don't develop that habit. So habit is a word which you frequently see. Okay, so in orthodontics also habits play a very important role. Let us see what are habits, what are the different types of habits, and what is a good habit and what is abnormal habit is something which is repetitive. So in that, what are the effects of habits on malocclusion? So coming to introduction, a habit can be defined as a fixed or constant practice established by frequent repetition according to Dorland 1957. So it is something like it is a fixed or a constant practice established by frequent repetition. So it is something like a fixed or constant and which is done frequently. Okay, Buttersworth in 1961 defined that a habit as a frequent or constant practice or acquired tendency which has been fixed by frequent repetition. So according to Buttersworth, what he says is habit is something which is acquired. It is not there at the time of birth, but which is acquired and which is done frequently. Okay, and it is fixed. It is deeply rooted or it is fixed. So that is according to Buttersworth. According to Mathewson in 1982, he defined oral habits as learned patterns of muscular contractions. So it is a learned pattern of muscular contraction. So it is not there at the time of birth, but it is something like which is acquired or it is learned, and which is where the musculature is also get habituated. Habits are thus acquired as a result of repetition. So in short, we can say that habit is a thing that which can be acquired, which is not there at the time of birth, which is acquired and which is done repeatedly, and it is deep rooted. Coming to what are the different habits which you should be worried in orthodontics. So the habit, different types of habits which is of our importance is thumb and finger sucking habit, tongue thrusting habit, and a mouth breathing habit. Okay, coming to what is thumb sucking habit. Okay, it is thumb sucking habit. It is the placement of thumb at various depths into the mouth. So putting the thumb into the oral cavity is called thumb sucking habit. Thumb sucking is normal till the eruption of permanent incisors. So some children will keep the thumb into the oral cavity, which is normal for certain age group, that is till the eruption of the permanent incisors. But if the persistence of habit beyond 6 years of age produces a damaging effects on the dentoalveolar structure. So if this habit is going to be persisted for a longer time, that is beyond 6 years, it is deleterious to the dentoalveolar structures. This affects a psychological disturbance suggestive of inability to manage the stress or anxiety. So something like these kind of habits which the child is doing, which shows that there is a lack of inability to manage the stress or anxiety. So every child has stress or anxiety at different milestones of development. So every child will manage by different ways. So those children who are doing this kind of habits should be identified and they have to be counseled properly. Some children are more nervous, shy or insecure than others and has emotional hunger, and they use thumb sucking to relieve tension. So as I told you, so generally children will adopt these kind of habits because of some kind of insecurity. Some children suck their thumb when they feel hungry, tired, afraid, restless, stressed, quiet or sleepy. So these are the different conditions where the child will feel comfortable by doing a thumb sucking habit. Others may resort to thumb sucking to alleviate boredom or to help themselves fall asleep. Sometimes some children feel like thumb sucking will make them calm, so they will resort to this kind of habits. Thumb sucking becomes a substitute for comfort, pleasure and safety. So from all all these things what we understood is thumb sucking is a habit which the children is adopting for various reasons. It might be because of anxiety, or it might be because of various reasons, but by doing thumb sucking habit they are deriving some kind of comfort or pleasure and safety. Coming to different types of thumb sucking habits, when you classify it is abnormal thumb sucking and a normal thumb sucking. Under abnormal thumb sucking we have a psychological and habitual. Okay, coming to the effects of thumb sucking. What are the different effects of thumb sucking? After placing the thumb for a longer period of time, over 6 years of age, will result in labial tipping of the maxillary anterior teeth. So maxillary anterior teeth will get proclined, there will be an increased overjet will be there, anterior open bite will be there, narrow maxillary arch, because the thumb is pressed against the palate, which will result in changing the U-shaped palate into the V-shaped palate or a narrow shaped palate. Lower anteriors are retroclined, increase in lower facial height due to supra-eruption of molars. So there is an increase in lower facial height also due to supra-eruption of molars. Why there is increased supra-eruption of molars? Because open bite is developed. Because of open bite, there is a downward backward rotation of the mandible also will happen. Spacing in between teeth and posterior crossbite. These are the some effects of thumb sucking habit. This is how the thumb sucking is done. Okay, the index finger or a thumb finger is pressing against the palate, which will leads to deep palate. So these are the side effects of or effects of thumb sucking habit. Here we have seen open bite tendency is there. Okay, all these narrow arches, all these are the effects of upper proclination, lower retroclination. All these are the effects of thumb sucking habit. How do you treat it? Is psychological therapy. First thing is psychological therapy. Parents should be counseled to provide the child with adequate affection and love. So sometimes these people like mother will be going out of job, or because of various reasons the child will feel that the mother or the parents are working parents, might be that might be one of the reason, like child feels such kind of insecurity. So the parent should be counseled to provide the child with adequate affection and love. Divert the child attention to other things is one of other thing. And beta hypothesis, it is nothing but conscious, purposeful and repeatedly making him sit in front of the mirror and ask to suck and observe. So beta hypothesis says that when a child who is doing the this kind of thumb sucking habit, you should ask the patient to continue that habit by standing in front of the mirror. So by seeing that, doing that kind of habit in front of the mirror, the child he himself feels that how awkward or ugly the patient he looks, and slowly they might they themselves give that self motivation will be developed. Coming to reminder therapy. So when this counseling does not work, then the second thing is reminder therapy. What is this? By giving a reminder, reminding that okay, you cannot do this kind of habit. That is a reminder therapy. So what different types of appliances or extraoral approaches are there, and different kinds of approaches are there. So in case of extraoral approach, what we give distasteful agents applied to finger or thumb, like pepper dissolved in a volatile medium, quinine, asafoetida. So what this is our like grandmother's concept. Like we are applying different kinds of chemical like asafoetida or quinine or pepper to the thumb finger, and when the child tries to put the thumb into the oral cavity, they feel that smell or pepper spiciness of the pepper, and they don't resort to that kind of habit because of the fear of that bad taste or spicy taste. And ace bandage approach, like an elastic bandage wrapped across the elbow, or use of long sleeve nightgown, all these things are different extraoral approaches. Like thermoplastic thumb post, this is one kind of habit which the child cannot keep if you give a band like that. Intraoral approaches is removable appliances which are passive, consist of a crib and is anchored to the oral cavity by clasps on the posterior teeth. By giving a crib also, this is a crib which is placed from inside. So this will prevent the child from keeping the finger into the oral cavity. Coming to fixed mechanotherapy, there is another appliance called bluegrass appliance by Haskell in the year 1991, which also acts as a thumb sucking, which will prevent the thumb sucking habit by using this appliance. Also other habit breaking appliances like fixed intraoral anti-thumb sucking appliance. This is also one kind of appliance fixed appliance which we use in order to prevent the habit. Coming to this is quad helix. Quad helix also to some extent the child cannot place the thumb into the oral cavity because that helixes are stopping, or the child may not get that pleasure of keeping the thumb into the oral cavity. Coming to other habit is tongue thrust. Tongue thrust is defined according to different authors. A tongue thrust is said to be present if the tongue is observed thrusting between the teeth and the teeth do not close in centric occlusion during deglutition. Okay, so this is a tongue thrusting habit, is also one kind of habit where the tongue pushes the pressure in the onto the teeth, okay, during deglutition. According to Schneider in 1982, he said that the forward placement of the tongue between the anterior teeth against the lower lip during swallowing is called tongue thrusting habit. So it is a forward placement of the tongue between the anterior teeth and against the lower lip during swallowing. Okay, definition of tongue thrust is the forward movement of the tongue tip between the teeth to meet the lower lip in the deglutition and in the sounds of speech so that the tongue becomes interdental. This is a habit. This is tongue thrusting definition. What is the etiology for this is retained infantile swallow for a longer time, upper respiratory tract infections, neurological disturbances, functional adaptability to transient change in anatomy, feeding practices and tongue thrusting induced due to other oral habits or tongue size. So the reason for tongue thrusting habit, why the tongue is pushed forward against the anterior teeth and why the tongue is trying to touch the lower lip is because of some underlined etiology. That might be because of retained infantile swallow. As you all know that there are different types, two types of swallows will be there, infantile swallow and a mature swallow. Infantile swallow is that swallow the child will adopt at the time of sucking the milk. So where the child folds the tongue and make like a straw, the tongue is folded in such a way that it itself acts as a straw and tries to suck the milk from the bottle or from the mother. Okay, that is infantile swallow. So here the tongue is taking the support at the bottom of the lingual side of the jaw. Okay, but when after this is for transient period. So once the child stops that feeding habit, he develops into the mature swallow where the tip of the tongue will support in the palate. In that way the food bolus is moved backward. Okay, but in case of retained infantile swallow means those children who adapts to the bottle feeding or mother feeding for a longer time, that is more than 18 months. Some people will do even more than 3 years or 4 years. In those children there won't be switching of the infantile swallow to the mature swallow. So in that conditions you will develop this tongue thrusting habit. Coming to some kind of upper respiratory infections also, because of some kind of upper respiratory infections the child cannot breathe from the nose, so instead of that they start breathing from the mouth. Because of that the mandible is drooped downwards, which also cause the tongue to come forward and start the tongue thrusting habit. Some kind of neurological disturbances also leads to tongue thrusting habit. Functional adaptability to transient change in anatomy. Okay, for example, because of transient change in some anatomy like erupting third molars or some kind of reasons or some kind of infections, nasal infections or something like that, which is transient, but the child adapt to the new position and continuing the same thing which also result in this kind of habits. Some kind of, as I told you, feeding practice practices and tongue also can be due to feeding practices also lead to tongue thrusting habit, and other oral habits like mouth breathing habit, all these lead to tongue thrusting habit. And also size of the tongue also sometimes is considered for a tongue thrusting habit. Classification according to Myers, the tongue thrusting can be classified as a simple tongue thrust swallow, complex tongue thrust swallow, retained infantile swallow, or tongue sucking. Simple tongue thrust swallow is tongue thrust with the teeth together a swallow. Okay, so here in simple tongue thrust both the sides of the teeth are in contact. In such condition it is anteriorly. Malocclusion will well subscribed anterior open bite will be in such kind of simple tongue thrust swallow. You will get anterior open bite or posterior teeth in perfect occlusion. Okay, open bite has definite beginning and an ending. Okay, usually associated with digit sucking, hence since it is necessary for the tongue to thrust forward into the open bite to maintain the anterior seal during the swallow. So the tongue thrusting, simple tongue thrusting, in this condition the occlusion will be there in the posteriors where the tongue is putting forward and leading to the open bite, etc. Complex tongue thrusting swallow, tongue thrust with teeth apart swallow. Here there is a tongue thrusting will be there, but here there won't be occlusion. Here there won't be, the teeth will be apart. Malocclusion, like poor occlusal fit prompts a slide into occlusion, or generalized anterior open bites also will lead. Mandibular elevators don't contract during swallowing, and mandible is stabilized by tongue and inframandibular muscle contractions in case of complex tongue thrusting. Usually associated with chronic respiratory distress, mouth breathing, tonsillitis and pharyngitis. In these conditions you will get a complex tongue thrusting habit. So in the habits like in conditions like chronic respiratory distress, mouth breathing, tonsillitis and pharyngitis, you will get a complex tongue thrusting, because what is in complex tongue thrusting, there won't be any contact between the teeth. The tongue thrusting will happen only with teeth apart, tongue thrusting. Okay. Also, tongue thrusting might also be caused due to retained infantile swallow or tongue sucking. As I told you, retained infantile swallow also lead to tongue thrusting habit. Undue persistence of the infantile swallow will pass the normal time for its departure. Teeth occlude on only one molar in each quadrant. Strong contractions of the facial muscles during swallowing. So here, because of retained infantile swallow, also this tongue thrusting is developed, as I told you. But here what happened, that there will be strong contractions of the facial muscles occur during swallowing, and teeth occlude on only one molar in each quadrant. Patients will have expressionless faces since the facial muscles are being used for stabilization of the mandible. Difficulties in mastication and low gag threshold. There is difficulty in mastication and also low gag threshold will be seen. Patients will have expressionless face since the facial muscles are being used for stabilization of the mandible. Coming to classification of tongue thrust, according to, there is one more classification of the previous one is according to Myers, and this is according to Brower and Holt, A1 1965. So type 1 non-deforming tongue thrust, according to him, the tongue thrust is type 1 is non-deforming tongue thrust, type 2 is deforming anterior tongue thrust, and in type 2 we have subgroup 1 which is anterior open bite, subgroup 2 is associated procumbency of anteriors, and subgroup Group 3 is associated posterior crossbite. So according to Brower and Holt, he had given type 1 and type 2 classification. Type 1 is non-deforming tongue thrust. Okay, there is no much deformation here. Whereas type 2 deforming anterior tongue thrust, again it is classified into subgroups 1, 2 and 3, where in subgroup 1 you have anterior open bite, in subgroup 2 it is associated procumbency of anteriors, and subgroup 3 is associated posterior crossbite. Type 3 is deforming lateral tongue thrust. Again in this we have subgroup 1 posterior open bite, subgroup 2 is posterior crossbite, and subgroup 3 is deep overbite. Type 4 is deforming anterior and lateral tongue thrust. Again it is classified into both is there here, deforming anterior and lateral tongue thrust. In this subgroup 1, anterior and posterior open bites will be seen. Subgroup 2, associated procumbency of anteriors is seen, and also subgroup 3 is associated posterior cross bite. Other classification is physiological, habitual, functional and anatomic. Here the tongue thrusting because of physiology. Normal tongue thrust swallow of infancy is called physiologic, whereas habitual is tongue thrust swallow present as a habit even after correction of malocclusion. It is called habitual. Functional is when tongue thrust mechanism is an adaptive behavior developed to achieve an oral seal. It is called as functional. And anatomic is persons with large tongue will have anterior tongue posture, which is anatomic. Because of anatomical conditions the patient is doing, that is called anatomic tongue posture. Because of functional reasons, that is when tongue thrust mechanism is an adaptive behavior developed to achieve an oral seal, that is functional. And habitual is something like even after removing the malocclusion, when the patient continues to do the same, then it is called habitual. Okay, effects of tongue thrusting. Thumb sucking plus tongue thrusting is if the finger displaces the maxillary incisors labially, the tongue thrusts forward to maintain the lip seal. Okay, accentuates the open bite tendency and prevents the incisors from erupting and forces them labial. These are the effects of tongue thrusting. Lips become more hypotonic and no longer contact each other during rest. Mouth breathing is aggravated. Increased overjet, lower lip cushions to the lingual of the maxillary incisors. Mentalis muscle activity increases, puckering of the chin is seen. Tongue drops lower in the mouth and no longer approximates the palate. Tongue elongates in shape and balancing effect on the buccal segment is decreased. Lateral peripheral portions no longer overlie the occlusal surfaces of the posteriors, and net effect is narrowing of the maxillary arch, over eruption of the posteriors, interocclusal space is eliminated and posterior crossbite is seen. Tongue thrust treatment. Simple tongue thrust should not be started before correction of the incisor proclination. So tongue thrust treatment is simple tongue thrust. In simple tongue thrust it should not be started before correction of the incisor proclination. Treatment. Training of correct swallow and posture of the tongue. Okay, so first we need to train the training and posturing of the tongue is adapted, and myofunctional exercises like the child is asked to place the tip of the tongue in the rugae area for 5 minutes and asked to swallow. Performance of exercises such as whistling, blowing, etc. are also being done. Okay, different types of mechanotherapies is for removable appliances, also crib, fixed habit breaking appliances, oral screens. All these are different types of steps. Steps in the treatment is myofunctional exercises is the step 1. Patient is instructed to swallow by holding the tongue tip against the junction of hard and soft palate. As I told you, myofunctional appliances training, and to practice the correct swallowing at least 40 times a day. And small elastics can be held by the tongue tip against the palate. All these are myofunctional appliances. Coming to step 2 is reinforce the new swallowing pattern subconsciously. Flat sugarless fruit drops can be used to place the drop on the tip of the tongue and hold it against the palate until the candy has dissolved completely. Have the patient time how long the candy is held in place, like that. Okay, step 3 is mechanotherapy, where well adapted lingual arch wire with a short 2 mm or sharp strategically placed spurs can be given and should not be placed as the first appliance. So whenever you are giving this type of appliances, first stepwise manner you need to do as step 1, step 2 and step 3. Coming to complex tongue thrust, to treat the occlusion first is the main thing. Muscle training should be started when the ortho treatment is in finishing stages. Instruct the patient to keep the teeth together during step 1. Step 3 is must, and maxillary retention appliance should have spurs incorporated in it. Coming to mouth breathing, it is like it is another habit where humans breathe to survive, and when the normal nasal mode of breathing is diminished, the survival system automatically programs us to breathe through the mouth. According to Sassoni et al., habitual respiration through the mouth instead of the nose. Classification is anatomic, obstructive and habitual. An anatomic mouth breather is the one whose lip morphology does not permit complete closure of the mouth, such as patient having a short upper lip. So that's why the patient is doing mouth breathing, which is called anatomic. Coming to habitual, is a habitual mouth breather is one who continues to breathe through the mouth even though the nasal obstruction is removed. So even the nasal obstruction is removed, he continues to do so that he is called habitual. Thus, a mouth breathing becomes a deep-rooted habit that is performed unconsciously. Coming to obstructive is due to deviated nasal septum, chronic inflammation, localized benign tumors, congenital enlargements of the nasal turbines, okay, allergic reactions of the nasal mucosa and obstructive adenoids. All these are obstructive in nature to the nasal cavity, which the patient cannot do with the nose. So he started doing breathing with mouth. Etiology might be allergies, physical obstructions, chronic infections, and thumb sucking or similar oral habits also might lead to mouth breathing habit. Effects of mouth breathing is one important effect is adenoid spaces, which is very important, where the child will develop long narrow faces, narrow nose and nasal passages, flaccid lips with short upper lip, buccal segments of maxilla are collapsed, leading to a high palatal vault. So these are the effects of mouth breathing. What is it? Because of mouth breathing, the patient drops the mouth, drops the mandible downward. Because of that, there will be constriction of the upper arch as the tongue position is placed downward. The upper arch is constricted, and because of lack of occlusion, the mandible will move forward, maxilla will move forward, and narrow nose and nasal passages. The lips also looks flaccid, and buccal segments of the maxilla are collapsed due to a high palatal vault and a lower position of the tongue. Overjet increases, anterior marginal gingivitis is developed because the oral cavity is opened, and because of mouth breathing, the gingiva get dried up, which leads to anterior marginal gingivitis. Dryness of the mouth is observed and anterior open bite, expressionless or blank face. Treatment is elimination of the cause, removal of nasal or pharyngeal obstructions, interception of the habit, exercises, nasal breathing exercises and lip exercises, and oral screens. Correction of malocclusion is another important. So elimination of the cause is first important thing, removal of nasal or pharyngeal obstructions, interception of habits, and the correction of malocclusion. Vestibular screen with breathing holes is one other appliance we generally give for mouth breathing habit. To conclude, oral habits have a definite bearing on the development of occlusion. One may acquire certain habits that may either temporarily or permanently be harmful to dental occlusion and to the tooth supporting structures. So such habits should be identified and treated as soon as possible. Thank you.